Okay, it's just little old me in here. Where the hell is everybody? I'm gonna close the doors and lock them. I'm not gonna let anybody in. Okay. Do 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 do. Do 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 do. I hope these people know how to get on here. They're such free loafers. I don't know what they're doing now. Wish they got on now. They're wasting my time. I want to hurry up and go now. Well, I want to watch TV. The blacklist is on and the Cowboys are losing. I want to see them blues. Where are the people that they wanted them to? Okay, I got Helen at least, but she hasn't come in the room yet. All right, Helen, where are you? Come on now. Come on. You're no Daisy. You're no Daisy at all. My little ducky. Put my ducky here so everyone can see. I'm waiting for these people to hurry up and get here because I want to finish up and go to bed. I got a lot of homework that I have to do if I want to be do. Boo, boo. Maybe I should just give them the link, huh? Okay, maybe we got to start over here. Where are you? But you were invited. Okay, hold on. All right. So you heard me singing, huh? I forgot that people can hear me. All right, let me try to fix this here. Invite people. There you go. All right, let's go to here. Boom. And send. Okay. That should do it. Let's see if that worked. Go ahead, give it a try, Helen. Yeah, I think it did work because I see you all in my Hangout page, all listed in the corner there. So I think you should be able to come on now if you wanted to, or if you can, anyways. Ah, there you are. You're coming in somewhere. Oh. What happened?
Do you hear me or see me?
No, I can't see you. I see your icon for your webcam, but I don't see you per se.
Okay, let's see.
That should do it. Let's see if that worked.
Huh.
Go ahead, give it a try, Helen.
I don't know why it's not, the camera is not going on.
Yeah, I think it did work because I see you all in my Hangout page, all listed in the corner there. So I think you should be able to come on now if you wanted to, or if you can, anyways.
Okay.
Ah, there you are.
Okay.
You're coming in somewhere. Oh. What happened?
Do you hear me or see me?
No, I can't see you. I see your icon for your.
Let me see. Let me see what's going on. Oh, I'm not sure why my camera is not turning on.
I don't know.
It turned on last time. Strange. Let's try this. Okay.
There you are.
There you go.
There you go. All right, right on. There you go.
So no one is watching, or
I don't know. I don't know. Well, I do see that there are 2 viewers. So, but I'm not sure if I'm included as one of the viewers. So.
Okay. But is this recording off of YouTube?
Yes, it is. So keep your conversation on, you know.
Oh no,
We're technically still, you know, at school right now. So.
Oh, okay. Okay. Shall we begin?
Okay, right on. Hit me.
Okay. So
I mean, I had a lot of response. It's kind of funny. I had a lot of response to people wanting to come on, and the funny thing is I have even though I did send up, I think I screwed up with the invite. I think I gave them the invitation to view it from, in other words, from YouTube, but I didn't give them access into this room. So I remedied that right now because on the very top here, I can basically invite more people if I wanted to. So it seems to be, yeah, obviously it worked for you. So let's just see if anyone else picks up on it.
I think Jonas is probably trying to come in too.
I think Jonas is trying to get in, but I just don't see him right now. So
screen.
Yeah. If any of you are listening, please, I sent you another link, another invite, and if you probably click on that, I'm sure you'll be able to access the room and come right in. So anyways, until that happens, I guess this is still just you and I for the first time. Since you were my baby student to begin with when we started this last week, I guess we can start again.
Okay.
So anyways, I got the whole Halloween motif going on back here. I thought I'd keep in with the spirit of things. I wish I had like a little jack-o'-lantern, or maybe what's that that one damn movie that Christmas and Halloween, or whatever, the Nightmare in Christmas or whatever.
Oh yeah, something like that.
Yeah. Well, anyways, aside from that, look at my sisters even chiming in on me, saying, "Where's your Halloween humor?" Okay. Anyways, Jonas is trying to chime in. There he goes. All I got is a green screen there, buddy.
Me too.
I think he's going to try to CGI us here. He's going to come on as one Frodo or
or Legolas or someone like that.
Maybe
I
he's
don't know.
camera shy.
Yeah, maybe he's gonna come in as Captain America.
I'm camera shy.
Okay, well that's fine. If you want to go that route, that's okay with me. All right, dear.
No, there's something wrong with my plug-in. That's why my camera's not showing up.
Oh, okay. Yeah, it did tell me that when I was setting it up, it said that because matter of fact, what's kind of funny is I have to do a whole presentation on Google Hangouts, and it did tell me that I had to instruct my students or whomever I was going to hang out with that if they're gonna be using this for the first time, that they're gonna have to go through a little series of installation of plugins. So, but they seem fairly easy, and I didn't have any issues with mine. Let's just say. So. I think as maybe you just have to maybe try to reinstall or something like that. See, there you're trying to, I can tell, but no, not right now. Anyways, okay, Helen.
Okay.
What can I do for you?
Would you like to ask Jonas first what he wants to go over? Because, well, before we begin, I think the whole class feels like they are not ready for the board exam. Because last week...
Hello, you're only a freshman. I mean, come on. What the hell? You think you're going to be ready to take the boards to next week? What the? I don't even know if I'm ready to take the boards.
Well, practically last week we took our final exam.
Yeah.
And it was just questions I've never seen from the previous modules before.
Oh, okay.
That was fairly new to us. Say, for instance, broncosol and isoproterenol.
Oh, shoot. Those are medications that I used when I was a baby therapist.
Yeah, basically, absolutely.
Some of you guys weren't even alive when I used those medications.
Exactly. So we were asked those questions, and along with, I think, another IPP machine that we've never heard of, like Bennett PR1 or something like that.
Yeah, the Bennett PR1 and PR2. They're pretty,
Bennett PR1 and PR2.
Right, the Bennett PR1 and PR2, they kind of look like little faces. You know, they're beige colored with little knobs that look like eyeballs, and they have a manometer that's sitting in the center of them. And then you have the Bird Mark 7, Mark 10, Mark 14. These are IPPB units that you can use as pressure ventilators if possible, but they're not designated as ventilators. That's kind of the weird thing about them. They're not considered ventilators, but at the same time you can use them because I've used them myself as ventilators. So yeah, they can screw with you. I mean, they have a tendency of being able to just confuse. But yeah, just be on the lookout. Like, for instance, if I was teaching your class at 210A, I definitely would have emphasized at the very least, the Bird Mark 7. That seems to be, if there is a IPPB that's out there right now, that's probably the machine that's utilized. Although I prefer, honestly, I do prefer the Bennett, the PR1, or excuse me, the PR2. I prefer that, but at the same time, why am I looking at me? Do you see me or you see you?
I see you.
Okay.
I can see you.
Oh, okay. Okay. I'm gonna put you guys up there because I'm tired of looking at myself here. I have enough of that. Okay. I don't need to see myself. I know how good I look. So.
Shouldn't your picture be in the lower right-hand corner? Because mine is.
Yeah, mine is, but my big head is in the center too. So now I have you there, and I would put Jonas there, but I don't want to just stare at green.
There's a plug-in error in my thing, so
okay.
It doesn't come up.
Okay, but can you see Helen and can you see I?
I can see you. I can see Helen.
Okay, good, fair enough. Anyways, so. Yeah, it stands to reason that that's something that you want to engage in. You know, I was even thinking about this because I could see this was getting a little bit out of hand very quickly, because as soon as I put out this feeler of the email for you guys to come and hang out with me, I really got inundated by a few emails, and I thought, oh crap, what am I going to do with all these different type of students in the class? So, Helen, like you remember the first time you and I spoke, you came up with a pretty good idea, and right now you just came up with another idea that I think would really work, and that is maybe if I continue on this path, and if it's still, you know, if it works, and if I can get paid for it, what we ought to do, or what I ought to do, is I ought to have like a couple of different sessions. Like, in other words, for instance, what time is it now? Okay, whatever. But this goes till 8 o'clock. Well, maybe I would have, for instance, at 8 o'clock to 9 o'clock, it would be purely NBRC type of questions.
Oh.
In other words, where we would just go over questions. I would have them posted here where you all can see them, and we would be able to interact with those questions, and then I can ask you, well, why are you thinking that way? Okay. See, the reason why I say that maybe we ought to do something like that is because, well, Jonas might have a question specifically about, for instance, the IPPB machine and how you would utilize it, being able to manipulate tidal volumes and I times, but yet you want to talk about obviously test questions like you just started off. So I can see that we would probably have a conflict here.
Right.
So I think that might be something worth thinking about or discussing. Hey guys, I mean, it's no big deal right now, but for the future, I don't know if I put it in my email, but if you notice, I'm wearing my my little earbuddies that I use for my cell phone, and it really comes in handy because, like, I don't know whose computer it is, but I'm getting a lot of feedback. I can hear myself speak.
Yeah, I can. Suddenly, it's like a lot of like.
Yeah.
Small.
So I'm getting, in other words, from your speakers, it's going from your speakers. My voice is going from your speakers right into your microphone and then feeding right back to me.
Oh.
You see? So if you wanted to try to figure out who's who, then all we would have to do is just have you mute your microphone, and then I could keep talking, and then I would be able to hear whether I hear my voice or not.
Okay.
So if you happen to have a set of earbuds, like, you know, like hands-free type of thing, then maybe you might want to, you know, utilize them or something like that. But or maybe even, you know, take the volume down a little bit on your speakers. That might even help.
Yep.
And by nature, you know, I'm a loudspeaker anyways. My wife is over here in the background already trying to tell me to shut up. You know, not talk so loud. So.
Or I think I have another idea. So if you were to do tutoring every week, maybe you can have the students vote on which subject they would like to cover. Say, like, you know, you put 3 subjects out, and then, you know, have them vote on whichever one they want, and then you can do the majority.
Yeah, that's a good idea. And another idea I was thinking is maybe I would do cohorts. You know, maybe,
okay, yeah.
You know, maybe I would do your cohort, which I think you're, what, September 13th or something like that?
January 28th.
Oh, January 28th. Yeah, you're the January 28th people. So in other words, I would have January 28th from, you know, 8 to 9 on Mondays, and then I would have you know, another cohort on another day. So I mean, it all depends on how we would play it. So
I think that would work out really well.
Right. Oh, thank you. Gotta have a drink, guys. Gotta have a drink. Okay. So, anyways, Jonas, where are you as far as your clinical site?
I'm at El Monte, sir.
El Monte. Okay. And
Jonas are together. We're together. Same day.
Oh, you're working at the same place?
Yeah.
At the same time?
Yeah.
Yes.
Oh, wow. Okay. Right on.
I was suspected to be a doctor in the Philippines, a underground JCO representative. So.
Well, you could probably pull it off.
No, I was trying to go with the flow. So I know how the system goes.
Oh, that's good. Oh, that's good.
But nobody knows that, you know, I'm an RT or something. So they know I'm a student.
you know, secrecy is sometimes the best policy.
Mm-hmm.
You know, so you know, you just keep in the background, you might be that much better off. You know, so this way, you know, nobody starts acting a certain way, and you know, they don't feel like they're, you know, I don't know.
Yeah.
You know, they'll just feel a little more strange. Like today, for instance, let me give an example. Is I was at Barlow in Van Nuys, and I went over there, and ironically, I went over there right during rounds. And so in Barlow's a very small place. It's kind of like the subacute area over in El Monte.
Yeah.
Okay, so it's very tiny. And anyways, I went and I stood behind outside the door as the therapist and the students were in the room, and they both turned around as if they knew someone was watching them. And ironically, you know, they both kind of like gasped, and then you know they kind of like got a little stage fright because now I was watching them work. And so you know, I tried to put them at ease, and I mean, I can understand you students. I know, I'm sure you, Helen, you would get a little uptight if I was standing behind you. But,
I would be, yes.
but at the same time, the therapist, I try to keep them at ease, and sometimes they get a little standoffish, and so I sometimes have to play my cards a little less bold, and I got to take a step back and let them feel like you know, they do have a say, and they are the controlling factor here. So, anyways, the point being is, you know, I can only try to do what I can, but you know, it doesn't take away from the fact that if people know that I'm an instructor, they treat me differently. So I'm sure Jonas would have somewhat of the same problem. You know, now I only show that I only have one. Helen, I think it's your speaker that's the problem, because Jonas, I could see here, he has his microphone on mute. So
yeah, I muted it because I'm hearing a lot.
So I can hear the feedback coming back from you.
Oh, so maybe it's mine. Let me try plugging the...
Yeah, just put your headphones on, and that might help.
Try using a headphone.
Yeah. There you
can you hear me?
Yeah, absolutely.
Oh, there's no more.
Okay, perfect. Now everyone's been muted out. Now that's good. Now, see, I don't hear any feedback anymore. That's nice. Well, anyways, my question is I wish somebody can tell me if anybody is watching us on YouTube, if you can see, because all I see is literally on my screen. All I see is that I have one viewer. Now, obviously, there's two of you in this room besides myself. So if there's anybody watching us on YouTube, if you can please just IM me on Hangouts, on Google Plus Hangouts, and let me know that you're there. I just want to see if there is a way that you can still communicate with me while you're watching me on YouTube. Okay. Okay. Well, now that that's been said, I'd like to open up the floor to whomever, you know, Jonas or Helen there. Do you have anything you want to talk about particularly, or is there anything that you would want to discuss or calculate, figure out? You know, what is it that you'd like to run across me?
Yes, sir. About we had a exam final exam last week.
Okay. Yeah. Right. Okay. Go ahead.
And one of the questions there was about the bird mark 7 appeared in Bennett. And there was one question that says there's these situations, or this will decrease the eye time.
I remember that.
Okay. So what I understood of the
question was specifically about was specifically for IPPB, or was it?
Yes, bird mark 7.
Yes.
Okay.
And it says these conditions, or this will decrease the eye time.
Uh-huh.
So the choices were there's a flow rate is high. The decrease in compliance.
I'm sorry. What are we talking about? Eye time?
Yes, sir.
Okay, go ahead. I'm sorry. Go ahead.
And the choices were the flow rate is high, decrease in compliance, increase in resistance, and two other choices that I can't remember.
Uh-huh.
And as I understood the question, it was Speaking of, I comprehended it as something you control manually, mechanically.
Oh, okay. So in other words, let me see if I'm understanding you. You're saying that, Jonas, you're saying that the question was leading you to believe if I wanted to alter the eye time, that
Yes.
What can I manipulate in order to do so? You didn't take into consideration the patient themselves breathing, their mechanics alone.
Yep.
So you felt that that was kind of like a sleight of hand type of question.
Yes.
Okay, I got you. Okay,
although it was a multiple question, but the thing was, the point of emphasis of the question was decrease in eye time. So
I'm sorry, do you say increase or decrease?
Decrease.
Decrease, gotcha. Okay.
So most of us answered like the flow rate is high.
The flow rate is high?
Yeah.
Yeah, an increase in flow rate will decrease the eye time.
Yeah, so that's the answer that we had, but the answers included decrease in compliance and increase in resistance.
A decrease in compliance and increase in resistance?
Yeah.
Of course.
That was part of the answer.
Absolutely. Yeah. Absolutely. Let me take this issue on, if you don't mind.
Yes, sir.
Okay, Helen. I'll address this to you too, because I already have an idea and have a feel for how Jonas will answer. So let me pose this to you. Okay.
Okay.
Do you get the idea of how eye time really works? In other words, our eye time represents what?
Our inspiratory time.
Exactly. In other words, what are we doing in that eye time?
What do you mean what we're doing?
What's happening in that eye time?
Oh, we're taking an inspiration.
Good. Excellent. Okay, so in other words, we're facilitating a breath, okay, for the patient to be able to take. Now, that breath is going to be dependent on how much time we're actually going to have, okay? Okay, now, if we speed up that flow, in other words, we increase the amount of flow, in other words, the amount of air that's going into your lungs, do you think that we will reach that preset pressure faster or slower?
Faster.
Absolutely, faster, exactly. So if we reach that faster, then would we say we're increasing or decreasing our eye time?
We're decreasing.
Exactly. Yes, we are decreasing our eye time because we're getting that air in so much faster that we're reaching that peak pressure faster than we normally would. So theoretically, we only need a short amount of time in order for us to accomplish this. Does that make sense?
Yes.
Okay. Now, let's go to what Mr. Jonas was saying in regards to a compliance issue. In other words, we're losing compliance, but we're gaining an increase in resistance. Okay, now remember what I taught you guys, okay, Jonas? Remember I taught you there's only two things that we really have to worry about. And what kind of patients do we worry about? Obstructive?
And restrictive.
Restrictive type of patients. That's all we worry about, okay? But remember, as a flow of gas is traveling through a tube, okay, it naturally meets up with something. Jonas, what is it that it meets up with?
Sir?
Well, again, let me paint a picture for you. If we had a 5-foot garden hose with the water on and a 50-foot garden hose with the water on, which one would appear to have the most pressure coming out of it?
The shorter one.
Yes. Helen, does that make sense to you?
Yes.
Yeah, because obviously as that tubing gets longer, as that hose gets longer, then obviously that we lose pressure. In other words, how do we lose pressure is by, what is the fluid? Let's just say in that 5-foot hose and the 50-foot hose, they're both putting out, no matter what, come hell or high water, they are both putting out 10 liters per minute of water. 10 liters. No matter what, both of them are still, but one of them is shooting out like a little boy peeing, you know, because a little boy peeing could pee like 10 yards. That's how strong he is, okay? But in other words, the longer the tube, the less pressure. So in other words, as we go through that tubing, we meet up with viscosity or resistance. In other words, the very water itself, the water molecules themselves, act as resistance against the tubing. So it slows it down. So have we increased or decreased resistance there? Through the 50-foot hose, I mean.
We increase the resistance.
We increase resistance. We do. We increase resistance. So, by that kind of logic, then, if we increase resistance, for instance, Jonas, what would be an increase in resistance on? What would be an increase in resistance in someone that has COPD? What would cause an increase in resistance?
Hyperinflation.
Within their lungs, what would be considered an increase in resistance? What would cause an increased resistance? Within the airways.
Compliance.
Physiologically, I mean, is the easiest thing, wouldn't that be mucus?
Yeah, mucus secretions.
Sure, absolutely, absolutely. Secretions, absolutely. That would be the easiest thing. Okay. Now, Helen, can you imagine though if we have an airway and we just say that the airway's like this? Okay, we'll just say it's kind of like that big. Okay. Now, if we have mucus that's contained in half of this area of where my fingers are, obviously it's no longer this big. It's now only this big. Now, for air, that same volume of air to get through there, would it have to increase that pressure or decrease that pressure in order to get through there?
You will have to increase the pressure.
Exactly. Remember what I used to call it, that driving pressure? Remember when I used to do that all the time?
Yes. That would be applicable to Persuade's law, right?
Right, exactly. Persuade's law, exactly. So with an increase in driving pressure, we would obviously, yeah, everybody take a drink right now, okay? I'm getting a little too uptight right now. So anyways, with an increase in driving pressure, that means that we're going, if we increase our pressure, aren't we increasing the flow? You see what I mean? In other words, in order for us to, remember, we're always trying to deliver the same volume. So in order to deliver that same volume, what do we have to do with that flow? Increase it or decrease it? If it starts meeting up with resistance?
Increase.
We have to increase it. Does that make sense?
Yeah.
Yes.
So we would have an increase in resistance, but how would we be able to prove that we have a decrease in compliance? In other words, Jonas, what I'm saying is, if we had an increase in resistance, would that reflect, as far as pressure is concerned, because remember, I did at least spend enough time with you to teach you that who do we always blame? Who do we always blame? Because we deal with volumes and pressures, but who do we always blame?
Pressure.
Pressure, exactly. We always blame pressure, even though we shouldn't be all the time. So the point is just that with the increase of resistance, do you think that that's going to increase or decrease the pressure, the delivered pressure, to get that same volume in?
Increase.
Ellen?
Yes. Increase.
Yeah, come on now. You got to stay with me. I only got two of you. I can't put you to sleep already.
No, you're not putting me to sleep.
Do you see that, or did I kind of lose you there?
No, I see it.
Yeah. So, in other words, if you increase resistance, then theoretically, in order for us to deliver that same volume, we're going to have to increase pressure. But you both know how to calculate static compliance, don't you?
Yes, sir.
Yes.
Helen? Okay, so what are the variables we need in order for us to do this properly?
Static will be
total
volume, yeah, divided by
and pressure.
PIP minus P.
Right, exactly. So we need, hold on a second, I got something going on here. Okay, sorry about that. Blink. Doink. Okay. Added you back. Okay, good. Where'd you guys go? I lost you. Oh, there you go. Okay. So we need tidal volume, okay, and we need a pressure, right?
Yeah, plateau and
yes.
And we need to subtract that, some PEEP from that, but that's not even a variable. We don't even need to worry about that, honestly. I mean, it is there, sure, but it's not something that we have to concern ourselves with. So, in other words, if this is simple math, we don't even need to whip out the formula. This is simple math. Look at, if you divide a big number by a big number, what kind of answer are you going to get?
small.
You're going to basically get this.
You're going to get a very small number.
Yeah.
But if you divide a big number by a small number, what kind of answer are you going to get?
You have a big value.
You'll have a larger value, exactly. So, if that's the case, then can you see why that a decrease in compliance and an increase in resistance would also decrease that I time? Because, Jonas, think about it. If there was an increase in resistance and we were using a volume ventilator, would the volume ventilator accelerate its pump or decelerate its pump in order to deliver that 500 milliliters for every breath? If it met with resistance, would it quickly jump to the top, or would it slowly glide all the way to 25 centimeters?
It will slowly glide.
No. Let me rephrase the question. Okay, how about this? If we have the end of our tubing, our circuit, our ventilator circuit, and we completely occlude it, and that volume ventilator tries to deliver that 500 milliliters, is that needle on the ventilator going to jump really quick to the pressure limit, or is it going to go very slow?
Quick, sorry.
Exactly. Now you got where I'm coming from. I just needed to rephrase it. Helen, does that kind of make sense to you?
Yes.
Okay, so in other words, as our pressure, or as the flow is being obstructed with or meeting with resistance, it will naturally speed up, trying to deliver that same volume. But in order to speed up, what does it have to do with its driving pressure? Increase it or decrease it?
It has to increase.
Increase. And if it increases it, do you think we're going to have a naturally moderate pressure that's going to show on our manometer on the ventilator, or do you think we're going to see this artificially high peak pressure on the ventilator?
High. Probably.
High pressures. So if we have a high pressure, let's just say that Mr. Smith's pressures are generally, let's put it in scenario form now, okay? Let's just say Mr. Smith's pressures, his peak pressures on the ventilator are normally 20 centimeters of water pressure, okay? Now, if they're generally 20 centimeters of water pressure, and we go on and we see that he's starting to accumulate secretions, and what is one of the indicators of noticing that they're accumulating secretions, Jonas?
Increase in peak pressures.
Yes, increased peak pressures. So we normally know him as 20 centimeters, okay? But now, Helen, he's around 20. Now, what is happening to that driving pressure?
It's going to try to increase.
It is increasing because we're normally 20, but now we're at 30, okay?
Mm-hmm.
So if we're at 30 now, it's because we already said it's secretions. So what are those secretions doing to the airway?
It's occluding it.
It's
giving
occluding
it more
it.
resistance.
Thank you. It's occluding it, but it's causing, the net result is an increase in resistance. Mm-hmm. So we have an increase in resistance, which would net what kind of a pressure?
High pressure.
A higher pressure. So if we take that higher number, okay, now remember, let's do simple math, okay? Okay, his tidal volume is 1,000 milliliters, okay? 1,000. Mm-hmm. His normal peak pressures, Helen, is 20. So what is his static compliance?
That would be 50.
50. 50. Very good. It's 50. Simple math. Okay, it's just 1,000 to take from 2. You know, it's just like 10 divided by 2. It's 5. So it's 50. Correct?
Yes.
Okay. Now let's change it a little bit. Okay. What is his static compliance now? If he's still getting the 1,000 milliliters, but his peak pressures now are 30.
Oh, that would be.
Or if you even want to say his
about
peak pressures now are
33.
33.
Yeah, like about 33.
33. So notice what happened to his compliance, Jonas.
Decreaser.
His compliance decreased, just like the question in your IPPB question, right? A decreased in compliance. And what caused that peak pressures to go up from 20 to 30, Helen?
Secretions, resistance.
Secretions,
basically.
which ended up being an increase in resistance. You see how you guys should have picked all 3 of those?
Yeah, I think there were like 5 multiple choices for us to pick.
Question. And how the question was
worded
written it was more into a decrease in eye time in terms of manipulating it. That's how I read it. So.
Oh, okay. Okay.
Mm-hmm.
Interesting. Okay. Well, you know what? Unfortunately, that is true. That there is a lot of type of a sleight of hand type of questions that kind of try to get your attention on one way, and yet it throws you the opposite direction, and you kind of get lost in this middle ground. Okay, so unfortunately, you guys just got caught.
Yeah.
So, oh my gosh, that exam. Halfway through, I'm like, okay, this is getting really hard.
So how many of you passed it?
A few.
I think 5, maybe.
A few?
Yeah. The questions were so
vague?
They were so tricky. They were so vague. And the thing was, honestly, for me, the time that I even saw or held a Birdmark 7 was in my internship year.
Yeah.
And during the time of the module that we were discussing the Birdmark 7, it was never mentioned to us. It was lectured to us regarding how the pressure will volume, what knobs to manipulate, but basically the internal structure and how these things will affect your breathing of your patient was never explained.
Right. And
they were like falling back on it because they said we're not yet in the ventilator management thing, but they threw out questions there that were about ventilator management.
Well, but okay, I get you.
So,
yeah. Let me ask you this question: when you were saying that about the IPPB, are you referring to your 210A class? Or are you referring to back home or
no 210A?
210A.
Okay, so 210A was kind of like, so I'm getting the gist of you saying that it was kind of like just breezed over.
Yep.
It wasn't very concentrated on.
Yeah, the thing that we discussed on mainly was contraindications and indications. That's it.
So the actual working mechanics of it, you didn't get into very much.
No.
Not too much. Like, we all didn't know what was the air mix percentage of the FiO2.
Yeah.
And the internal components of the IPPB when you do an inspiration. Which way does the diaphragm move? We didn't know that at all.
Yeah, that's kind of tough, because you got to remember you got to know that one side is sensitivity side and the other side represents pressure, and how it actually works. Jonas, when you were in the Philippines or when you were over in the Middle East, I mean, you didn't use any IPPB at all?
No, sir. The only time I used IPPB was in the Philippines during my internship, and that was it.
Right. Okay.
Never
Well,
did I.
and I don't fault you for that, because honestly, I'm one of the believers that they should IPPB should be outlawed, in my opinion. It should literally be it is
obsolete.
Literally, dinosaur is obsolete. It is an obsolete therapy. I can share with you many of research paper that I've written or that I've read and that I've written about, and that basically proves that IPPB is a non-functioning type of form of therapy, but yet there's some Yahoo in Kentucky that's still using the bloody thing, so they're still going to put it on the NBRC exam. Mm-hmm. So unfortunately, we still have to have that cross to bear. So it's unfortunate, but
I think Glendale is still using it, because I believe Lizette was telling me that
she
actually used the Mark 7.
Yeah, don't get me wrong, Helen. They do still have them. I mean, for instance, Kindred has one. City of Hope has one. A lot of these hospitals in the area, they only have one. Okay, but that should tell you something. There's a reason why they only have one, and more than likely, the reason why they have one is because they still have this 85-year-old doctor that's still practicing there, that doesn't want to retire, and he still thinks that IPPB is going to help his patients. So you see what I'm telling you? So take it for what it's worth. You know. I mean, I'm all in favor of change, but sometimes it's some things are not good to bring in from the past. I mean, sometimes they're best left in the past. So, that's. I hope I explained that, Jonas. I mean, I hope.
Yes, sir. I just wanted to clarify, because I did choose the 3, but when I read the question again, it was more towards how you will manipulate decreasing eye time.
Right.
The thing here is, I was like Helen mentioned about the diaphragm thing, going to the left or to the right. I was imagining how it was working. But the thing is, how about my other classmates who just saw the bird mark 7 in the lab and didn't touch it, or just didn't know what it is? So they're at a disadvantage, basically.
Yeah, definitely. I can see that. That's a problem, unfortunately. I'll tell you how I teach. Okay, I generally, for instance, I have Mr. Georges at my clinical site, right?
Yeah. Yes.
And literally, I am literally testing him based on where he should be. So in other words, I am giving him NBRC questions, literally, and I am giving him questions that I developed myself, okay? But at the same time, they're particularly geared for where he is in his education at this time. So I don't throw him any curveballs, like I don't put any pediatric type of questions on there, neonatal type of questions, or any PFT type of questions. I don't go that route, because I know it's not appropriate for him at this time. I would rather him understand the fundamentals that I have given him up to this point, and so he can better move forward and apply those in different type of questions. You see. So it's a bit of a crapshoot sometimes, that are we sure that this is what we want to utilize, so it's a tough one, guys. It's really tough. Helen, did you have a question on your own? I mean, Jesus, look at the time. It's time.
Yeah, no, it's already time. Maybe next time we can cover more. I think I would like to go over like hemodynamics.
In what sense? In what respect?
No, I'm not really sure where to start at all, but I know it's very important for us to know our cardiopulmonary and plus our renal, and I feel like I just need more coverage on hemodynamics because
Can I ask you a question?
Okay.
Were hemodynamics discussed in your section up until now? Hold on. I did give you hemodynamics in your cardiovascular section before I left. Okay,
yes.
are they referring to that?
Yes.
Okay. Okay. So what you need to do, honestly, I mean, I hate to make this sound like I'm putting you off, but what I would suggest you doing first is I would suggest you not necessarily memorize. Okay, you don't have to do that. I mean, it would be nice if you started to know these things, but but for instance, remember I told you guys once that like I do it on mine. Like I have my Samsung tablet here. That's all dirty because Ducky uses it every time she comes over today, and she was just that's her coloring right there and all her little stuff there. But anyways, I use see there's Ducky's artwork right there.
Oh, it's nice.
Yeah. Anyways, I have flashcards on here. It's an it's an app. Obviously, it's an app, and I just put on my flashcards there. And believe it or not, my flashcards have on there hemodynamics. And every now and then, when I'm at Kindred, I just flip through them, and I see what I should be always reminding myself of. Because I mean, I rarely use this stuff. So, and again, I'm very big on if you don't use it, you lose it.
Yeah. That's
so. What I would suggest you doing first is make yourself a little cheat sheet. Really, just make yourself a little cheat sheet. And how you could do this is simple. You don't even have to open Egan's if you don't want to. Go literally straight to my slides, the slides that I gave you.
Okay.
Okay, and go to that section, which I think, if I'm not mistaken, I think it's like 100. It's around 100. Slide number 100. Okay. And that's where the hemodynamics begins, where the CVPs, you get your CVP pressures, your PAP pressures, your wedge pressures, okay. And when you get there, write down those numbers, those values, and what do they mean? In other words, if you had an increase in CVPs and you had a decrease in PAPs and a decrease of wedge pressure, then don't you think we might want to start thinking about right heart failure?
Yes.
Because that's all coming from the right heart, right? If our left heart is okay or fairly okay, but our right heart, in other words, our CVP pressures are sky high, then doesn't that tell me that there's this back pressure, and where's that blood supposed to be going to? The lungs. Well, if it's going to the lungs, then it's causing that back pressure, then maybe it's a right heart type of problem. See? So if you did that, maybe either A, you would answer your very own question, or B, it would open up other questions for you to be able to ask directly.
Right, okay.
See,
I just feel like...
Go ahead.
Because, I just feel like, we're in clinicals, and all we're doing is, giving treatments, suctioning, and helping them write numbers down.
Are you both doing it at the same time? Both of you?
No,
yes,
we're different. Oh, well, yeah, together, yeah, same time.
They're there at the same time, you two.
Yeah.
Okay.
Wednesday, Thursday.
Okay. Yeah, I mean, Jesus, that's a tough one, man. I mean, you got and you really don't have any insight to what those numbers mean that are on the monitor if you're in the ICU.
That's what I wanted to understand. They'll tell us, okay, this is the numbers you have to write over here, and over here. So just jot those down, and we're just inputting. We jot and then we input in the computer.
Yeah.
But do we know? When we look at the number, I want to be able to look at the numbers and be like, hey, maybe this is contraindicated, or maybe we should do this instead.
Right. No, I wholeheartedly agree with you. I mean, there's nothing like wanting to be able to, like, for instance, I was again, Jonas, you didn't have the ability to be with me and Helen last time, but we had a little bit of a party of our own, and one of the things that her and I were discussing was the fact that how different the life is from being in our respiratory classroom versus being in the hospital itself, and seeing all the doctors, the nurses, even the therapists walking in and out of rooms that have CRE, VRE, MRSA. and they're not wearing any gowns, or they're not wearing any gloves, or they're or they're just not even checking their ventilators properly, like the way they're
really
supposed
surprised.
to. Yeah.
Honestly.
So yeah, unfortunately, right now, Helen, like I was telling you, well, you know, you are supposed to be a neb jockey right now, but I told you one thing though. I appreciate the fact that you would like to get into hemodynamics, and believe me, your hemodynamics is going to be more emphasized in your next term starting next week, because it's not in my section. If you remember, I don't know if you can remember. I mean, obviously you don't remember every word I said. It'd be nice if you did. But I know you guys don't remember every word. But when I introduced you to your hemodynamics, I specifically said to you, because I say this to every one of my students at this time, that I said, you know what, I'm introducing this to you, and I will mention it every now and then, but it's not going to be a focus point. This is more of a focal point when you get into your ventilator class. So keep that in mind. Keep that in mind. And if you do your homework right now and make yourself a little cheat sheet now and become familiar with it, when both of you start next Tuesday, you're going to have yourself a pretty decent head start on when they start talking about pressures, you know, heart pressures and whatnot. So I would
it's funny because it's funny that Jonas mentioned the IPPB and how resistance and compliance affect you know, your eye time. But last week I was in ICU, and I was, you know, jotting down numbers, helping the therapist jot down numbers, and I noticed, you know, the PIP was about 30 to 40, but this patient, her usual PIP is like around 20. So and I just thought, like, strange. So I just thought, like, oh, maybe I should suction her and see what happens. So I did. I suctioned her, and it went down immediately.
Well, you know what? So next time, both of you, please, next time, because this is the fun time, man. This is the fun time. Next time, what you ought to do is record all your numbers first. Record all your numbers, and get your plateau pressure. Have you been able to figure out how to get a plateau pressure yet?
Yeah, the inspiratory hold.
Yeah.
I don't know that.
Yeah, you want to just use your inspiratory hold, and Jonas could probably help you when you're there. And you just want to utilize the inspiratory hold for about 0.5 seconds. Now, between me and you, I don't want to get off the topic too much, but between me and you, if you really want a true plateau pressure, you want to hold that patient for about 5 seconds.
Yep.
Oh, okay.
Yeah, if you want a true plateau pressure, you want to hold them. Okay, but don't do that. Don't do that. Don't do that. Okay, that's off the record. Don't do that, because other therapists think that you're nuts if you even try to do 1 second. Okay.
Okay.
So, anyways, do it that way. Get all your numbers, and then start doing your calculations. In other words, start doing your compliances and see how that works out.
I did.
Okay.
Remember, Helen, I told you that I was writing it in the charting thing.
Oh yeah, right on.
I was typing it in the electronic charting thing that they have.
Okay.
And my preceptor said, we're not documenting those, but I have all the computations in my sheet, ventilator sheet. So I erased all of it and said, we're not documenting those. So, okay.
Right.
But at least I wrote it. So.
Yeah, and that's another thing. That's why I suggested to you to get one of those. Just go to the 99-cent store or Staples or something and get a tiny little spiral notebook. You know, one that could fit inside your pocket. Okay. And then whenever you have a question about something, when you ever want to note something down, you don't want it to be on the record, but you want to get the numbers, just write them down, and then we can look at them later on. Especially blood gases, guys. Especially blood gases. Write your blood gases down, because I'm going to ask you, damn it, what was your ventilation at this time? And then you're going to say, you know. So you wanna get all that information down before you do it.
Okay.
Okay.
Yeah. One question though, sir. Last one.
Yes, sir.
I noticed that when they start mechanical ventilator here, they don't use PEEPs.
What do you?
They don't put PEEP.
Oh, PEP.
They don't use PEEP at all?
No, it's 0.
Really?
And
You know, that might just is Dr. Not Sanduk, but Dr.
Rambatla?
Rambatla.
No, not Dr. Rambatla. I know Dr. Rambatla, but no, he's a tall Indian fella.
No, I don't think I've ever seen
I've
him.
never seen him.
Sanjay, no. Anyways, he was very particular. So I didn't know if maybe he was still involved with Greater Omani or not. So I don't know.
Mm-hmm.
But you know, Jonas, the only thing I could say about that is it just has to be the peculiar acts of the physicians themselves and how they view their therapy. Somewhere in the line, they were taught that you don't need to have PEEP. You don't need to. You could do it all with IPPP, or excuse me, with FiO2 and with appropriate tidal volume.
Mm-hmm.
You know, I don't know what to say about that, honestly. I mean, I'm a very big supporter of PEEP therapy. You know, frankly, I'm a big supporter in using 10 or more centimeters of PEEP right off the bat. You know, I don't care. Let's do it. You know why? Because I can use a lot more pressure and use very tiny tidal volumes, and I could probably get that patient off a heck of a lot faster than somebody using larger tidal volumes and no PEEP at all.
And I noticed that they only approximate tidal volume in the sense that it's either 500 or 450. I don't know why.
500 or what?
450.
450.
Always.
Yeah. You know what? We call that the usual. The usual. So in other words, I'm standing there with the doc, and I go ahead and intubate the patient, and I'll look at the doc and say, the usual, doc? And they'll say, yeah. And so I'll know to put them on AC of 20, 450, and 100%, and a 5 of PEEP. I'm just giving you values that we used to use at City of Hope. I mean, at City of Hope, it was always AC of 20, 450, 5 of PEEP, and 100%. Boom. It was the usual. So I didn't ask for weight. I didn't ask for size. I didn't ask for any of that stuff. You just always know to do it that way because that's what the doctors like. But remember, guys, that's not what we're about right now. We're about the NBRC, and the whole point is we're going to go work at the NBRC General Hospital for 4 hours when we take that NBRC exam, in other words. And when we do, we got to think like an NBRC therapist, not like a RT. Yeah. Jonas, did you get the highest score in that final last week?
No, I think Helen got it.
What? No, it's John.
John who?
Okay.
John Markland.
No.
Yes.
Impossible.
I barely passed.
Impossible.
John Markland has the highest grade.
I forget that this is being recorded. I'm just kidding, John. Okay, I'm just kidding. Anyways, no, that's good though. That's good. You know, he has a little bit of a background though, doesn't he? He has a what's EMT or something like that?
Yeah.
Yes, EMT.
Yeah. So no, you know what? The reason why I ask is more than likely, Jonas, if you don't mind me saying so, you probably fell victim to the old saying that I've always told you guys that, you know, if you think like a respiratory therapist,
you're gonna fail.
Yeah, you're not gonna do so well on this exam. You can't think like a practicing one rather. If you think like a practicing respiratory therapist, oh boy, you're asking for trouble.
Yeah. Honestly, I was at a dilemma at the start. But I tried to convince myself that I'm not an RT and I'm a student, and it's working well so far.
Good, I'm glad. I'm glad because I mean,
in the clinical stuff, like in El Monte,
yeah,
I do notice some stuff that I know from my practice that hey, you should do this, hey, you should not do this, but I'm not saying anything. The thing is, I'm adjusting myself in my perception that you're a student and you should be in this type of zone, what do you call it, type of area only. So I think it's working out fine, basically.
Right. Okay. Okay.
Also.
Well, yeah. Well, guys, I think we got to come to a close here. I'm sorry it went so fast. Helen, I think you probably have the smartest idea so far. Maybe there's something that we ought to discuss in advance, like maybe even post your questions in advance.
Yes, sir.
And then we can immediately address them, and then we can probably hammer out a little bit more items. And maybe I can do a little bit more serious thinking as far as maybe one time we could be having a session in regards to what you are being taught at the moment. And then another session can be about test-taking skills and bringing questions and saying, okay, now how are you going to do this?
Yes, sir. That's good too.
Yeah. And I think you, especially Jonas, I think you would have really appreciate that one a lot more than the most of them, because frankly, Jonas, I think you're more than ready. But nevertheless, because this is obviously a formality, that I think you should just be really beefing up on your test-taking practices.
Yes,
and
sir.
I think you're going to be fine other than that. Honestly, it's both of you. I mean, I think you're both going to do relatively, it's not going to be a problem for you. It's just getting you there, though. You know what I mean? I just have to get you there.
Thank you, sir.
Yeah, absolutely. Okay, well, like I said, I'll evaluate this. I'll look at this. I'll see how stupid I looked and on the video, and then I'll reevaluate and see how we can maybe cut through time, because obviously, again, I am a little long-winded, but maybe we can streamline this, and maybe take 2 to 5 topics at a time. We can cover a little bit more ground and maybe feel a little bit more better about ourselves when we walk out of here.
Yes, sir.
Yes.
Okay?
I think this will improve and get better and have a better structure.
Yeah. Okay, cool. So anyways, thank you guys for showing up. I really appreciate it. I really hope that some other students, I did get a message from someone else that they did see it online, but they're not in the room with us, but they did watch it on YouTube, so I just got that message, so that was kind of cool. And I just hope that there's others that are in the YouTube, using YouTube in order to watch us, and maybe next time they won't be so afraid and join us. Maybe that's what's the matter. They're afraid of what I'll say to them. So.
Maybe I should blank out my screen next time, like Jonas.
Oh my! Wait a minute.
I'm on YouTube now.
No, you're fine. And Jonas, fix that computer of yours, my friend. I'd like to.
Yes, sir. I'll just try to fix this plugin or something.
But of course, again, please, I thank you very much. And if I can help you in any way possible, shape, or form, please don't hesitate. I'm not just restricted to just this Monday night and us doing this on a formal basis. If you had something like, for instance, Helen here was a little pushy and she was timing me at 11 o'clock last night, saying, "Do you want to fool around on Hangout?" But at some time there might be a time where I might say, "Yeah, I'm available. What do you have in mind? What do you want to talk about? What is it that you need clarification on?" So if you want to do that, I mean, please feel free. You never know. There might be a time where I am available and I can do it on a Wednesday night or whatever night it is, or even during the day. So just hit me up and I'll do my best to try to make it work for you. Okay?
Yes, sir. Thank you,
sir. All right,
sir.
guys. Again, thank you very much for showing up, and I'll let you know when we're going to have our next one. Okay?
Yes, sir. Thank you, sir.
All right. Bye.
Yes, thank you.
Good night.
Bye-bye.
Good night.
Good night.